So thanks everybody for logging in this evening. It's another Neurotrauma webinar, and this time the presentation is by our neurosurgical colleagues in Belfast, and basically it's a presentation on sport-related head injuries, which is a very interesting topic. And Mr. Theo Hurst and Mr. Philip Weir are going to present their experience with this, and I'm sure it'll be a very interesting presentation. Just before we start, if you have questions, use the chat function to put your questions up, and I'll read them. If you're not presenting, please switch off your mic and your camera. And the next meeting is probably going to be on the 5th of April, but I'll announce it at the end. So I think, Theo, you can start. We have plenty of people online now.
Okay, great. Can you hear okay and see the screen okay? Yeah.
We can.
Good stuff. Great. So, well, thanks for having me. First of all, my name is Theo Hurst, one of the senior regs in neurosurgery at Belfast. It's hoping to chat about some of our recent experiences with sports-related head injuries. We're based in the Royal Victoria Hospital, which is shown here. It's maybe photoshopped or something, so I'm not sure what that blue thing is at the top, but anyhow. So, I mean, many of you will know as well as us, or if not better, that concussion and traumatic brain injury is a common issue across all sport, particularly in contact and combat sports, and it's associated with a number of issues. You know, with these are young, healthy patients. We know there's a lot of evidence coming out that, especially with repeated injuries, there's real risk and problems with early and late sequelae from those. We wanted to describe some of our experiences and focus in particular on the return to play issue. And I suppose it's contentious for the same reasons. These can often be difficult and nuanced decisions. And the reason for that is there's multiple competing issues at play. And I suppose the evidence or the guidelines can not be the most straightforward to navigate at times. So we have 3 cases. I'll just run through these in succession to start. The first one is a 16-year-old male. He has no medical history, and he was referred to us in the autumn time of last year. Is playing a hurling match, wearing a helmet, and took an impact to his right temple. He fell to the ground, lost consciousness for a couple of minutes, was taken off the field where he was confused on waking, brought up to his local ED, where he recovered to being alert and oriented with no neurological deficits. Did have a temporal laceration at the site of impact, and his imaging looked like this. So we've got 2 slices from his brain CT, just showing the brain tissues, and the left 2 images here and here, and then the bony windows on the right. And the anomaly to see was a depressed skull fracture with a bit of extradural air and blood just underneath it, and evidence of a contusion just underneath that. You can see the fracture line in a bit more detail on these images on the right. They're from roughly the same position as the 2 images on the left. And we can see there's a free-floating fragment with about 1 centimetre of depression. This is all contained to the squamous part of the temporal bone. There was no mastoid fracture component, and his CT scan was otherwise normal. So we transferred him up to the neurosurgical department. On admission, he looked pretty well, actually. He again had some headache, but otherwise no neurological deficits. He was cognitively bright, Didn't have any issues with CSF leaks from either his scar or nose or ears. The laceration was sutured in the emergency department, I think. And ultimately, we established a plan for conservative management. He had a repeat scan after a couple of days, and that showed no change in the size of the hematoma, the extradural hematoma, that is, although the area of contusion had become a little bit more prominent, as we see in these cases, but overall sort of satisfactory. He ultimately did well, progressed well. His headaches settled down reasonably smoothly. Didn't have any issues with seizures. Did describe some reduction in the hearing of his right ear, but again, he had no mastoid fracture. Didn't have any facial weakness, so we weren't overly concerned about that. He was discharged on day 4. He was reviewed by our ENT colleagues shortly after. He didn't end up getting an audiogram, although on their review his hearing loss had resolved completely, so they were happy enough. And ultimately, seeing him in the clinic about 3 months later, he was very well. He'd essentially made a complete recovery. He was back to his normal self. No post-concussive or post-head injury symptoms to report at all. He was back to school, doing well in that regard. And from a neurological and cognitive perspective, had no problems whatsoever. His scar had healed well, and no cosmetic issues with the depressed fracture. And here's a scan from February there, which shows that, well, you can see, particularly on these images on the right, there is still a little bit of depression on that there, the site of the fracture. It's healed well. There's nice bony union, and there's no evidence of gliosis or significant parenchymal signal abnormality underneath. So really, is a case where we've managed things conservatively. He's had essentially a perfect neurological outcome, or a very good neurological outcome, and he's happy from a cosmetic perspective as well. So there's no indication for any further surgical management. The second case was again from I think the autumn of last year. It's a 34-year-old man who, with no medical history again, he was a welder by trade, although boxed semi-professionally. In part of his training for an upcoming bout, he was sparring in his gym. Took a few punches to the head as part of one of the sessions and decided to stop early, sitting things out because he was feeling unwell. Essentially, he developed a headache, sat things out, and had ongoing headaches for the rest of the day. He nonetheless decided to get back to it a couple of days later. He again took a couple of heavy blows during a sparring session, although on this occasion he describes falling to his knees, a possible brief loss of consciousness followed by a vomit, but had ongoing severe headache after that. He was imaged in his local, presented to his local emergency department, and had imaging which shows, well, from which some slices are shown here, and the obvious abnormality is a left-sided subdural hematoma. From a sort of a surgical perspective, it is, or from an imaging perspective rather, it is a surgical one. By that I mean that there's mass effect. There's maximum depth there is 60 millimeters. That's a midline shift. The third ventricle and basal cisterns were effaced. So on that basis, transferred him down to our department. On arrival, aside from quite significant headaches, he looked okay. He was alert and oriented. He had no focal deficits other than some pronasal drift on the right-hand side. So ultimately, we discussed options with him and proceeded to a craniotomy the following day, again, because of the degree of mass effect and his symptoms. Surgery was uneventful. He made good progress, or sort of worked well from the surgery. He did have an episode of facial twitching, which was not felt to be definitely a seizure, and he had no anti-epileptic medications either at the time of the event, or no routine or regular medication started following it. He was a bit slow to get up and going in the coming days. He didn't have any definite or gross physical issues, although our OTs did identify a sort of an issue with his higher cognitive functions. Post-op CT looked pretty good. We can see a good resolution of the hematoma. These are roughly equivalent slices to the ones I showed before. Sorry. And the degree of mass effect is reduced. He was discharged after 10 days. He was advised to refrain from any further contact sport until we saw him in the clinic. We gave him the other standard sort of driving and post-surgical advice for these patients at discharge as well. In the clinic, he was doing better, but still not back to his normal self. He had some ongoing issues with fatigue. He was feeling dizzy, although a lot of the dizziness was positional, or had a positional element. And did respond at least partially to whole pike maneuvers. But I suppose importantly, he wasn't yet sort of feeling well enough to get back to work. And he said right from the start that he was struggling to know what to do with himself without his boxing, as that had previously that had been really important to him. And the third case is another 16-year-old, so school-age boy with no medical history again. He's a keen rugby player, played in the school team, and actually presented to us in January after going to his optician. He described some visual blurring and maybe some intermittent horizontal diplopia for, I think from memory, a week or two prior to that. They found bilateral papilledema, although no other definite abnormalities on his visual assessments. By that I mean ophthalmoplegia, field deficits, or severe loss of acuity. Quite surprisingly, his scan, he was sent to his ED, and surprisingly his CT showed quite a sizable chronic subdural hematoma. So again, 4 slices from his brain CT. We can see most obviously this extraaxial lesion just here in the right frontal region. It is similar density to the brain tissue, but you can see elements of it lower down and higher up as well. There's mass effect on the associated brain. We can see there's some midline shift as well, and some partial effacement of the third ventricle. So again, a surgical scan, significant pressure effects. Although surprisingly, in our experience, 16-year-olds with hematomas this size are generally very sick, but he had no symptoms other than his visual ones. So on this basis, we did, this basis on the features of his CT, we did wonder about whether he might have an underlying lesion, such as an arachnoid cyst. The reason we thought about this specifically is that there is possibly a bit of thinning or scalloping of the frontal bone here, and the Sylvian fissure, despite the degree of mass effect, is larger than that on the left, or more prominent than that on the left side as well. So again, we admitted him, we had a chat with him. As we said earlier, he's a keen rugby player, he plays for his school team. He describes in that setting having had a bang to the head, one a year ago, or over a year ago, one again a number of months prior. He had a low speed motorbike collision in the summer. So again, that's what, 6 months prior to his admission. Although wasn't really sure if there was a head injury or any contact at that point. He remained well, and aside from his papilledema, had no deficits. We recommended surgery because of the papilledema, of course, and he had a craniotomy and had a straightforward evacuation of the chronic subdural fluid that we encountered. And inspecting the frontal lobe, at least, I couldn't see any evidence of a definite arachnoid cyst or other abnormality on or over the cortical surface, and that was down to the superior edge of the Sylvian fissure. Ultimately, he did very well post-operatively. He has no symptoms except for a bit of scalp tenderness, as you'd expect, and his vision settled down nicely. A scan shows a good reduction in the amount of mass effect, at least. We can see there's still some fluid in the subdural space, which is common after these procedures. But there's little midline shift. The right lateral ventricle has expanded nicely. The third ventricle is more prominent. So again, in keeping with a good outcome. But on this sequence, at least, this is an early post-op scan. Unfortunately, we don't have a later one to hand at present. There's no definite evidence of an arachnoid cyst, but it's something that we've still been a little suspicious of going forwards. So that's a fairly quick run through 3 cases. We've selected them because from a sort of inpatient clinical perspective, from a surgical procedure and decision-making perspective, they've been relatively straightforward. They're all cases that have actually done quite well, and it's good to see. We've got, well, 2 different mechanisms of injury, and the third case with an unclear mechanism. 2 which have had symptoms, 1 hasn't, 3 different sports. But despite all of these differences, there's been one common theme across the board, and that's at the point of discharge and in the clinic thereafter. They've all said, when can I get back to my sport? Hurling, boxing, rugby. That's really important to me. That's the number one thing that I care about ultimately. And that's been a really difficult question to answer in those cases, even though actually their clinical course and outcome has been pretty good. The return to play issue is, as we know, very contentious, and the reason for that is that there's a lot of academic and media attention as to the long-term sequelae, particularly with regards to neurodegenerative disease that's come about. And here's just titles from a couple of articles highlighting that issue. At the top, from in an academic setting, but also we see this in the media. We've seen this quite frequently propping up in the media in the last few years, and for good reasons. Willie Stewart's group in Glasgow have done quite a lot of work on this issue, but there's 2 papers to mention at this stage. And the first is looking at former professional football players. They have essentially documented a pretty strong association between the volume of exposure to heading football and neurodegenerative disease incidence. And what I mean by the volume of exposure, it's what positions they played, how likely they were to be heading the ball, but also the length of the professional career. Similarly, looking at international rugby players, there again is a strong association or increased incidence of neurodegenerative diseases, that's dementias, Parkinson's, motor neuron disease, compared with matched control comparison groups. And that's sort of, again, has been highlighted recently, for example, with the unfortunate death of Dottie Weir. And sort of closer to home for us in Northern Ireland, at least, we have unfortunately seen a case of second impact syndrome, following which a school-age boy suffering 2 concussions within a rugby match has unfortunately died, and that's again a tragic case. So I guess coming back to the return to play requests, if you like, so somebody in the clinic saying to us, "Doctor, when can I get back to it?" There's a few questions, to me at least, which sprung to mind when considering this issue. And that is really, what are the guidelines for return to play at present? As neurosurgeons, it's something that we're not exposed to perhaps quite as frequently as many of those of you in the audience. And I guess as an extension of that is, well, what is the evidence base underlying it? Why are the guidelines as such? Is the guidance different between different sports, different ages of athlete, different types of head injury? Is there a difference according to the level of sport? We know that particularly in professional sport, look at the Premier League for football or the NFL, there's a huge volume of supporting staff and support for the players, which is obviously very different when you compare that to grassroots sport, if you use the football example. Who makes the decision when it comes to sort of discussing or permitting or authorizing a return to play? Is there any advice specific to patients with a more significant injury? So what I mean by that is somebody who needs a long hospital admission, somebody who has low conscious level, somebody who requires surgery, really the sorts of injuries that we in the surgical setting might come across more frequently. And I guess finally is, what is the additional risk with an early, or what is this all here to prevent? What's the problem with an early return to play? What is the additional risk of long-term degenerative issues or mental health impacts? And what is the risk of second impact syndrome? Probably my understanding and my reading, the most influential document or set of documents seems to be the consensus statements for concussion in sport. There's 5 iterations, the last of which was produced after a meeting in Berlin. They've been on the go since 2001. The current issue describes screening of 60,000 articles, although does appreciate that many of the data underlying this, their recommendations are from relatively smaller observational studies. And consequently, we see that a lot of sporting bodies derive their protocols for concussion management, return to play management from these guidelines. And there's just a few examples highlighted below. I think of relevance, they define concussion as essentially any traumatic brain injury occurring in the sporting setting. So a traumatic brain injury induced by biomechanical forces. Certainly the neurosurgery teaching in our textbooks would define concussion as a traumatic brain injury with symptoms and a normal CT. So it does differ in that regard. The recommendations are designed to be applicable across all sport and all head injuries, as I said. And I suppose importantly, it's not directly, even though it's published within a medical journal, British Journal of Sports Medicine, it's not directed specifically to medical legal readerships, but it applies to everyone, general public, sporting bodies, athletes, coaches, parents, etc. They describe 11 R's as the key points in concussion management, and I've summarized a few of relevance just here. And they include recognition. We won't go too far into that issue, again, as it's not something that we have direct experience with, but what it means there is on the field, after the insult, they refer to neurophysiological changes, but also possibly structural changes. What I mean by that is really an anomaly visible on a plain CT. But I think more importantly, they describe a concussion to be something associated with essentially any symptom. They can be varied, vague, they can onset either immediately or a bit later, and they can last for essentially a relatively unspecified period of time. They don't offer a hierarchy of symptoms. So, for example, is loss of consciousness or headache or drowsiness more important or factor more greatly into considerations than other more nebulous symptoms? And they don't specifically allude to, in their document, any universally accepted objective tests. On diagnosis, of course, athletes should be removed and rested, and most importantly here, they specify that they should rest until they're symptom-free. But again, they don't specify what symptom. and they don't specify an upper limit of the time frame. The basis for this is that we know that there are cognitive and physical sequelae to an injury. We know that even without a structural injury, something visible on a CT, there is a pathological process going on within the brain cellular environment, and that an early return to play confers an additional risk that we'll discuss a bit more a little bit later on. They admit that the definition of a recovery is difficult. There's no gold standard or precise definition. They briefly discuss the role for objective measures such as imaging or laboratory tests, but really confine that to the experimental sphere at the point of publication in 2016 at least. They identify that those with younger age or worse symptoms, or those earlier sort of higher impact injuries and pre-morbid mental health issues or migraines may be prone to a greater risk and also have slower recovery times. And on the basis of those things, this is where the graduated return to sport strategy comes from. And essentially, this is a multi-stage program by which an athlete has complete physical and mental rest for usually at least 24 hours, and then must take a minimum of a day for each step going forwards, essentially through light, then more heavier sort of aerobic activity, and then finally working on towards proper training, contact training, and then full play. If an individual develops any symptoms, again, without any specific definitions there, they should stop and go back a step and stay there until they can manage without symptoms. And we see that that framework is reflected in return to play guidelines. Here's two examples from the IRFU on the left and World Rugby on the right. And if we look on the right, importantly, the World Rugby guidance suggests that following a concussion, an adult, so someone over 19, has a minimum time before returning to gameplay of 12 days, and those of school age or under 19 or longer, 19 days, so a significant exclusion period. Similarly, if we look at the GAA, for example, we've a hurling example. In our cases, we see a similar framework. And I suppose if we go back to the Berlin statement, if we think about any specifics there or that stand out, or anything that isn't really mentioned, they specify there shouldn't be a difference in management between top level and grassroots athletes. Although it's of course the real world management in that regard is different. For example, if there's medical reviews, imaging, availability, that sort of thing. We said that adolescents and children are more vulnerable, so should have slower return to play times. But I suppose for us in the surgical setting is they don't make any specific reference to those with more significant head injuries. What I mean is those with a WHO defines a moderate or severe head injury, or those requiring surgery. When it comes to persistent symptoms, they recommend a multimodality approach, although don't really specify much more beyond that. Their concluding statement is acknowledging this and the incomplete understanding of concussion. They basically say that the management of concussion and return to play really, at the end of the day, it's down to sensible, pragmatic decision making for individuals, which I suppose is understandable. Some inferences that I made from this is there's a few things that have very broad definitions. For example, what is a concussion? How do you identify it? How do you exclude it? They describe a concussion as any head injury with symptoms. Others describe it in a different way. But I think more importantly, there's no framework to sub-classify a concussion or a head injury in terms of apportioning a level of risk in terms of acute or chronic sequelae. What I mean by that is, our first case had a focal injury. He's got a small area of brain that has been injured, possibly just as a direct consequence of his depressed fracture. And pathologically, physiologically, that is a different injury to somebody with a diffuse injury, like the second patient, or somebody who's lost consciousness. I think something that is challenging is the fact that there isn't a way to define or prioritize what symptoms are most relevant, what timeframes are most relevant. Or at least that hasn't been done in this document. Similarly, when it comes to the return to play issue, the definition of symptoms, their recovery, diagnosing recovery, if you like, and stratifying sort of future risk is very broad at the minute, and that I suppose is the main issue at hand when it comes to these return to play questions. From our perspective, these guidelines appear to be developed and targeted mostly towards, I suppose, what our textbooks would say a true concussion, and that is the majority of people with minor injuries who have symptoms that last for a relatively short period of time after. So what I mean is not those who have significant deficits, who need operations, who need a long hospital admission after their injury. What about combat sports? We know that the guidance is a little bit different. If we look at the boxing example, the AIBA have really quite specific and strict rules when it comes to concussion, head injury management, and also the return to play. For example, any boxer to be sanctioned for a bout needs regular medicals. There must be a ringside doctor present at every bout, regardless of the level. And if there's any evidence of a concussion, then there's strict, there's clearly specified guidelines as to how to stop the bout, what to look for, and when to stop the bout. And we see that the Association of Ringside Physicians have correspondingly have a more precise definition of concussion, its diagnosis, and return to play. There are pre-specified minimum suspension periods if a bout is stopped because of head injury. What I mean by that is a knockout, or if the referee stops the contest because of a head issue. So if they feel a boxer is concussed, for example. And accordingly, there is a minimum exclusion period for any boxer after this, according to essentially the severity of the concussion, if you like. At the end of this period, a boxer must have a medical, and it is recommended that they have cranial imaging, either a CT or an MR, which is something that we haven't seen mentioned explicitly in the other guidelines. There is a list, at the point of the medical, there's a list of disqualifying conditions, which include, understandably, things like acute infections, pregnancy, liver disease, this sort of thing. But relevantly, from a brain injury perspective, if there's visual acuity issues, a boxer will be excluded or disqualified. If there's unresolved post-concussive symptoms, if there is a seizure within the last 3 years. But I think most relevantly, again, for our second case, if there is a significant congenital or acquired intracranial mass lesion or bleeding, which sounds specific, but actually it's a really broad term, and we'll come back to that a bit later on. So we can provide some advice to our patients after looking through these guidance. But what happens if they say, actually, I'll be okay the second the boxer has gone back to training despite having symptoms of his concussion? So I suppose, again, if we look at the literature and say, well, what are the risks in that setting? What is the risk of second impact syndrome? What is the outcome of it? Does it actually exist? And if we have an early return to play, is there an increase in risk of the long-term sequelae of the neurodegenerative issues? Second impact syndrome is a bit of an area of debate within the literature. Some people argue that it doesn't really exist, that it's just a significant response to other processes. Although I think most people would agree that it exists in some form, although the main debate is as to how best to define it. All the currently described definitions have a unifying feature, and that is that following an injury, you get a disproportionate malignant cerebral edema. And that has to be after 2 concussions occurring within a reasonably short time frame. McCrory in '98 specified that there shouldn't be a structural abnormality, something detected on CT. However, more recent definitions or papers have observed that subdural hematomas commonly occur in the setting. But importantly, when this is the case, the degree of cerebral edema is disproportionate, far beyond that should be caused by mass effect or injury from the subdural. So I suppose on this subject, or the question that would come on from this is, well, what is the minimum or maximum interval between head injuries that you need to be at risk of second impact syndrome? Is there any particular mechanisms, types of injuries, or risk factors for it? There is a good systematic review published again in 2016 by a group from Indiana, looking at these questions. They've searched, including people or athletes with 2 observed impacts, subsequent neurological deterioration after the second one, imaging showing significant cerebral edema, not fully explained by something like a subdural. They have to have had post-concussive symptoms after their first injury and some form of medical evaluation after the first injury. And the reason for the 4th one was so that they could describe what sort of symptoms these athletes had at that point in their process. They identified 36 probable SIS cases, of which 17 fit their inclusion criteria. Most of those exclusions were, I think, because of a medical description of their symptoms after the first injury. Interestingly, they were all male. They were all young, so mostly teenagers, with a handful in their early 20s. And the majority happened in the setting of contact or combat sports. So we can see boxing, karate, AIF is American football. I think really importantly, and this probably is one thing that helps to explain why we have this nebulous description of concussion symptoms, is very few of these individuals had a loss of consciousness at the point of their first injury. In fact, only 4 out of the 17 did. The majority had headaches. However, this was not universal, and the absence of headache has not precluded the development of a second impact syndrome. And actually, 2 of the cases here, one individual just described feeling dazed, which again is something that we would see understandably as a concussive symptom. But another one described an obsessive behavior to box again, which is certainly not a classical symptom that many of us would consider. Then looked at the second injuries. These happened across a relatively wide time frame, anything from 1 hour up to 4 weeks from the first injury. It was mostly a mild injury, so again, the type of concussion that we see commonly on the pitch. And what I mean by that is something that there may or may not have been some loss of consciousness, but there's generally been an initial good recovery. It's not that the individual has had a The second event has been a moderate or a severe traumatic brain injury or anything like that. They generally have been awake and then had a collapse a short while after. So, for example, some of the American football cases have played a few more plays and then collapsed without any further injury. They describe a subdural hematoma in every case. However, the cardinal feature was the malignant edema with or without herniation, which was far beyond that which you'd expect from the subdural. And tragically, of these 17 cases, 6, a third, have died, and another 4 have had disabling neurological deficits. So, in other words, over half have had a bad outcome. While it's a small case, there aren't any obvious correlations to see between the nature of the first or second injury and the outcome. But I think more importantly, the interval between injuries and the outcome. So, for example, the case of the longest interval between injuries, 4 weeks, had a poor outcome. That boy unfortunately died. And there are some cases with injuries a couple of days apart, with a good recovery described. When it comes to the mechanism or the pathophysiology of it, some would argue that, well, it's not universal by any stretch, but we do see diffuse and significant edema in pediatric traumatic brain injuries. And, you know, is this an issue, or is it just that they have an exaggerated response to an enlarging subdural? But actually, I think the most accepted mechanism is that following the first injury or following any concussion, particularly in these young individuals, we get a loss of autoregulation, which means that the brain is hyperemic, the vessels are engorged, and so following a second injury, those mechanisms aren't intact for the brain to be able to focally reduce blood flow in order to suppress or compensate for edema. And what happens there is obviously is a positive feedback loop. So edema causes an issue with cerebral blood flow, which then causes more edema, and we get this rapid escalating process. In terms of the risk factors, aside from observing that they're individuals, it's difficult to investigate anything beyond that. There's no obvious other features with these individuals or their histories or their injuries. This group do theorize that migraine may be associated with a greater risk because those individuals have more severe concussive symptoms, and certain genotypes, for example with ApoE genes, may again play a role, although that's all really speculative. When it comes to the long-term risks with early return to play, so is there anything to say that there's an additional or a summative risk with an early return to play of long-term neurodegenerative disease risk or other conditions? I'm happy to be corrected. I haven't been able to find any data directly supporting this, although for me, it's logical that an athlete who has concussive symptoms and is performing suboptimally is more likely to sustain a further injury. But also, if we have in the setting following a concussion, a microenvironment within the brain with disordered autoregulation, with inflammation, with metabolic derangements, then surely it is sensible to think that brain or that cellular environment is more prone to or less resilient to the effects of an additional injury. So it certainly, to me, seems logical that long-term risk may be magnified in that early return to play or early period phase following a concussion. So I guess if we think about this, these points, and go back to the Berlin statements on return to play, you could say, well, the second impact syndrome cases have all been young males. So why is it such a broad policy? And I suppose there's a few things that might suggest that, to my mind at least. The first is it's obviously very much in the public interest to minimize risk. These are young, healthy individuals with hopefully long or many years of good quality life ahead of them. It's injuries in sport, particularly if it comes to second injury, is a preventable issue. So it's entirely preventable morbidity and mortality. And so, that logically means that the obvious answer is, if in doubt, to be more cautious. But secondly, it's because I suppose we know so little about the concussion issue, or there's so many areas in which we could know more at least. We don't have ways to stratify with 100% certainty those who definitely have a concussion and those who don't, for example, after a blow to the head or a punch or whatever. And for those who do have an injury, we don't have a definite way to say with confidence which injuries are associated with greater early or long-term risk, other than really those in young adults and teenagers. And finally, it's aside from the symptoms somebody has, it's difficult to say with certainty when someone has recovered, or in other words, when the phase of that risk of additional injury has definitely passed. I suppose if we think a little bit more detail about issues that might underpin these points when it comes to the diagnosis of a concussion or a mild TBI, we know that athletes are highly motivated individuals. There is a possibility that they might underreport concussions. One study looking at college American footballers found that only 1 in 27 concussions was actually reported in the formal channels. And if we think about boxers, they very much have an incentive to continue in their bout if they have had a punch to the head and not feeling quite there. It's almost in the very nature of boxing to do so. We mentioned already, do different types of injuries cause different pathophysiology, and consequently all those differing pathophysiologies or overlapping processes associated with different risks, and we don't really know is the honest answer. But the more that this is looked into, the more we realize that concussion or mild TBI is not just something that you can brush off and go on to. Actually, Willie Stewart's group have looked at postmortems of older people who've suffered concussions, but shortly in the period shortly after have died of other causes, and have found evidence of mild diffuse axonal injury. There are obviously ways of assessing athletes for objective evidence of concussion. So for example, with the sport concussion assessment tool, it's in its 5th iteration. Again, it's not my area, so I'm not going to go into that in too much detail. But again, the question could be there is do we have a clear understanding of its sensitivity and specificity? And I'm not sure we have a 100% answer in that regard. Finally, are sports comparable when it comes to risk? The Berlin statement says essentially yes. However, again, by the nature of the sport, boxers suffer multiple punches to the head in a bout, often in training as well, although they'll often have protective gear at that point, of course. They're more likely to continue, and yet we haven't necessarily seen a disproportionate rate of second limb back syndrome, even though many of the professional boxers are within, or just about within, that young, early 20s age category. There's a very good discussion of concussion and its issues within the UK, at least. I've included the reference later on. They do, in response to some of these questions, provide a slightly more specific diagnostic criteria for concussion, although it's clear there's still a bit of a way to go in that regard. And then coming back to how do we define recovery? As we said, the only guide is symptoms, and therefore a graduated return to play system is logical. If somebody if we build things up, if somebody's feeling unwell, then obviously we can go back to it. However, we can go back a step. However, as I said earlier, we've only seen second impact syndrome cases in young adults. So for the boxer, for example, is a protocol designed to prevent second impact syndrome, is it valid? Again, I don't think anyone is going to say we haven't seen any SIS cases in somebody in their 30s, so yeah, it's fine. But again, it's just a question that came to my mind reading through these studies. There are some areas of progress or interest, particularly with respect to imaging. We know that diffusion tensor MR seems to be a pretty sensitive tool to detect diffuse injuries and therefore concussions, in particular type or of relevance, maybe types of concussions that might be relevant. However, its applicability as to the role for, whether the presence or absence of changes and its relevance for return to play is yet to be defined. And I suppose one concern is if we look at top level rugby players, for example, is it going to become an issue, or would it become an issue that we see actually these sorts of injuries very frequently, and are we going to end up with an over exclusion of individuals? Again, that's something that time perhaps or further work will tell. There is some work looking at biomarkers, for example, with salivary microRNAs currently. That is something that can be taken and tested from the pitch side, although the precise role, particularly when it comes to return to play, is not quite defined just yet. I'm running a bit over, so apologies for that, but I'll just come quickly to...
We might just actually, it'd be nice to have some time to discuss.
Yeah, okay.
So if you could wrap up, that would be great.
Yeah, I just quickly discuss the three cases, and then that's us really. So number one, it's the case. The first case is relatively straightforward. He's done very well. He's recovered. He doesn't have any surgical questions. So I think if he follows the standard return to play guidance, that I don't really see that being a major issue. A question from the literature review is, does he actually have a diffuse brain injury, and what's the relevance of that question? We don't know. Second one is the second case has a subdural that essentially is listed as a disqualifying condition, and therefore he's very unlikely to be able to box again. Does that apply if his subdural resolves without surgery? Is a question that could be asked. Would you let someone box if they have a bone flap? I think most surgeons would say no. And the AIBA is pretty clear as to who would make that decision. Interestingly, I have found a study looking at subdural hematomas in boxing. Actually, of that series of 6, 2 have boxed again, although they both had very tiny non-surgical subdurals. Finally, the third case, I suppose, doesn't really meet the Berlin Statement's criteria for being a concussion. So by extension of that, you could say, well, does return to play guidance apply for him? But I think the main question for him at present is whether or not he has an underlying lesion, such as the arachnoid cyst, and whether or not it's okay to let him play rugby, given that he has a frontal craniotomy bone flap. And I think probably in all of these cases, but in his in particular, as advised, a pragmatic discussion of risks is probably what is required. I have a few concluding points there, which essentially just summarise what we've spoken about, but maybe it's better to get on to the discussion. So
I think we will be cut off by Teams soon if we don't. That's great presentation, Theo. Thank you very much. Very thorough, and you covered some really, really important points. I think the whole issue of return to sport is really, really important. We may actually have another session on sports, because the whole thing needs to be a little bit discussed with people and see what different people suggest. I think you touched on the fact that there's guidelines for concussion, but not so much for what a lot of us as neurosurgeons see, which are more severe injuries. And do any of the other neurosurgeons online want to say anything, or have they? There is one question here in terms of driving, but the driving guidelines are actually all in the Road Safety Authority and the DVLA. I think one of the issues is, I mean, this you talked about people who obviously have had an injury, but sometimes when you have a patient, say, with an arachnoid cyst, you're asked, without any injury, or any bleeds, and just a patient who's diagnosed with an arachnoid cyst, and they ask us, well, can I do contact sports? I've generally been very, very liberal about it, and I tell them, yes, they can. But I don't know if there's any guidelines for that,
I mean, the only thing that I'm aware of really is this fairly nebulous AIPA, the boxing guideline, that says if somebody has a congenital mass lesion, then that excludes them. But again, I haven't seen anything to elucidate on that, or specifically, what that includes. Does that include cysts? Is it tumors? Is it hematomas? Is it something else? And whether or not size or whether they have symptoms from it has any relevance. So that's the only thing I'm aware of. And yeah, it's, as you say, it's a difficult thing to deal with, right?
Yeah, it is. A lot of the guidelines, as you say, I suppose aren't that helpful in the sort of cases that we see. I think at one of the previous webinars we presented a 17-year-old who was rushed in here after a rugby match with a blow to the head with an acute extradural, and he actually fixed his pupils, and we had to rush him to theatre. He's made a fantastic recovery from that, but his question is, when can I go back to rugby? I've told him 12 months, but I kind of picked that out of a hat because there isn't really something that we can say it's evidence-based guidelines.
I haven't found anything to say if you have a craniotomy bone flap, does that make it okay or not okay? Is it relevant that whether or not the bone has reintegrated? The paper looking at subdural hematomas in boxing, while all the patients who had surgery for the subdural were disqualified from boxing again, they did highlight a couple of cases of boxers who'd had neurosurgery for other conditions. One that springs to mind was somebody had a excision of a cavernoma. However, again, I don't know the details of that case. If, for example, if it's boxing where you're always facing your opponent and they've had a midline post-fossa craniectomy, then that's a very different kettle of fish to having had a frontal craniotomy, for example.
Okay. Very good. I think that was an excellent overview of the sports-related injuries, and particularly in terms of going back to sports. And obviously, as always with these things, it raises more questions than absolute answers. And we desperately need kind of better studies for sports-related injuries, which would generally have to be kind of multi-center with large numbers to answer these sort of questions. But thank you very much for a fantastic presentation. I don't see any other desperate questions or anybody putting up their hands, and I'm hoping our next webinar will be on the 5th of April, but I'll confirm that by email through the RCSI. Phil, thank you very much, and Theo, thank you very, very much for a fantastic presentation.
Pleasure.
Thank you.